Hello. In this session, we're going to be talking about the broad topic of why breast cancer can't be cured. And I think that is probably somewhat a misconception because we have to think about breast cancer across a spectrum. So for patients with metastatic or advanced breast cancer, our therapeutic approach is to control the pace of the disease, to shrink it, and ultimately to make patients live longer. But unfortunately, in 2026, we don't have a cure for breast cancer. So the goal of any treatment approach in patients is to palliate, which means to eliminate any symptoms that they might be experiencing from their cancer, as well as to hopefully, by shrinking the tumor, delaying the time until it progresses, we can actually extend a patient's overall survival. Now, in contrast, patients with early stage disease where there hasn't been spread to other organs in the body, in most of those situations, the goal of therapy is actually cure. And we approach that patient very differently than somebody with metastatic disease. Now, in those situations where cure is really the goal, we may incorporate not just what a medical oncologist provides, but also a surgeon and a radiation oncologist. And we'll talk a little bit about that as we go through it. In all of these situations, it takes a team approach to manage the patient. Even in patients with advanced disease, although the surgeon is very infrequently involved, radiation oncologists are, medical oncologists are, of course, other team members as well. And in patients with early stage disease, the spectrum of people involved include the surgeon, medical oncologist, radiation oncologist, sometimes a reconstructive plastic surgeon, geneticist, etc. So it's a team approach to managing patients with breast cancer. To the question of why breast cancer can't be cured, it goes to the biology of the disease. So when we think about a breast tumor, or for that matter, any solid cancer tumor, lung cancer, colon cancer, whatever. We think in a very simplistic way, well, everything's the same if you look at the cells in the tumor. But actually, it's not the way the cancer cells look under the microscope. And even more importantly, if you were to go another layer below and look at the molecular makeup of a tumor. So tumors are composed of many different cells. They're all breast cancer, but each individual cell might have some features that are different. So in other words, when we look at a breast cancer, one of the common things we try to evaluate is whether or not patients' tumor cells have estrogen, progesterone receptors, whether they're HER2 positive or not. And that already tells you that different breast cancers can be different. They're categorized differently based on those features. But even in an individual patient, if you were to analyze the metastases from a specific area and look at it, you'll find that tumor cells are not all identical in that same patient. All breast cancer, but the features might be different. There are some cells that are strongly hormone receptor positive, others that are not, some that are HER2 positive, others that are not. So when we think about why a disease responds, sometimes it's a function of the treatment we're using is particularly effective against one subset of the breast cancer cells. And it may in fact eliminate them and have little effect or very modest effect against other tumor cells that don't have that sensitivity. And that's why a cancer can either recur, come back, or why the tumor does not completely disappear in the advanced disease setting, even though there's been some evidence on scans that you see shrinkage, but inevitably the tumors will start growing again in the advanced disease setting or develop in some other area of the body. Why does this occur? Well, as I mentioned already, there's heterogeneity, meaning all the cancer cells are not the same. And the other thing that happens over time is that you get evolution of changes in tumor cells. And by that I mean that tumor cells can acquire different mutations that make them behave differently. And that is really the root of why drug resistance develops. So if you're treating somebody effectively with a particular therapy, be it chemotherapy, even an anti-hormone therapy, a HER2-directed therapy, over time, particularly in the metastatic disease setting, advanced disease setting, the tumor cells will figure out how to bypass the effect of that drug. And ultimately, the tumor cells start growing again, and you see evidence of disease progression, indicating that that particular therapy that you were using is no longer effective. And it's at that point that the oncologist would typically pivot to something else. Now, the other thing, again, in our era that happens relatively frequently is we try to reevaluate the tumor over time. So we don't think it has suddenly changed from breast cancer to some other kind of cancer, but rather we want to understand the mutational profile of the tumor. So many oncologists will sometimes suggest a re-biopsy, not to find a different kind of cancer, but to reanalyze whether the hormone receptors or the HER2 status has changed. Sometimes what is called next-generation sequencing or molecular testing is done, and this is something that can be done on tissue by biopsy or also utilizing circulating tumor DNA, in other words, a blood test. And what the oncologist is looking for is the development of any mutations that may have come along under the pressure of the prior treatment. The reason that's important is because we now have targeted therapies that can sometimes prove useful if you have a particular mutation that's developed. So this is an era which we refer to as medicine or targeted therapy, and that really reflects improvements in how we approach patients, meaning that not every therapy works for everybody and everybody should get every therapy, but rather selecting the one that is best for an individual patient. So molecular testing is part of our routine approach to patients with metastatic disease today. And slowly it's starting to find its way even into patients with earlier stage disease, where the intent is cure. The reason the disease comes back in patients with early stage disease, so we'll take the example of somebody who shows up that has a breast tumor located in their breast. Maybe they don't even have any lymph nodes that are involved, and they undergo surgery. Maybe they've had breast conservation, they get radiation therapy to the breast, and then depending on whether they're hormone sensitive or not, might get a recommendation for anti-hormone therapy, which would be administered for several years, or adjuvant chemotherapy. And again, the purpose of all of those treatments is to eliminate microscopic disease that may be present. We don't know because you can't see microscopic disease. So why is it the disease shows up again? It's because in some patients, that therapy did not completely eliminate every last tumor cell. And when that happens, tumors can lie dormant, or I should say tumor cells can lie dormant for years, and then for reasons we don't understand, become active again. And when that happens, you see evidence of that based on patient developing symptoms, or perhaps scans were done for some other reason, and you see that there's evidence of activity of the disease, and now this patient has recurrent metastatic breast cancer. So in that situation, we have to completely reassess the disease. Years might have gone past since the original diagnosis, and we have to make sure the characteristics of the disease have remained the same or they changed. And accordingly, we would plan on utilizing the appropriate therapy based on what we find at the time that the disease recurs. When you interact with your oncologist, one of the hardest things to understand is that you want to be involved in decision making and feel like you have control, or at least some element of control. We always try to educate patients as best we can, and we encourage them to learn as much about their situation as possible so that they can make informed decisions. Oftentimes patients ask about diet and exercise, all of which are important not only for your general overall well-being, but in many cases, some of those things actually have an impact on the course of the disease. So learning as much as possible, as well as trying to maintain your level of activity, is critically important, and we encourage you to do so. And you can get more information at yerbba.com for other suggestions and other programs that might help you. Another mechanism that cancer cells are able to utilize is they're able to evade the immune system. And in essence, by hiding from it, our natural system that we're all built with to get rid of, say, infections is not effective oftentimes with cancer cells. Cancer cells have evolved in such a way that they can basically shut off the components of the immune system that would otherwise identify the tumor cell and eliminate it. So one of the strategies that we're now utilizing in many patients, but not all, because it's only effective to date in certain subtypes of breast cancer, is immunotherapy, which is not necessarily treating the cancer, but treating the immune system to decrease tolerance to the tumor cells. So in other words, basically turning on the immune system so that it can effectively treat the cancer. And that is a strategy that has proven effective in patients with triple-negative breast cancer that don't have the hormone receptors that are present, estrogen and progesterone receptor. And if they have other markers, both in early and late-stage disease, this can be a tool that is added to chemotherapy that has been shown to be effective in many patients. So that is a whole area of research that continues to evolve, and the hope is that as we go forward, one of the strategies will be how do we optimally employ immunotherapy with chemotherapy, with antibody drug conjugates, with even anti-hormone therapy. But at present, the biggest place that immunotherapy has is in select patients with triple-negative breast cancer. The current state of research for patients with advanced disease is really to optimize the therapies we have. So as I've spoken in the past, we have silos of disease, hormone sensitive, HER2 positive, triple negative disease. We have different therapies that are effective in each of those spaces, but one of the challenges is how do we make them more effective? So we've learned that with, as an example, anti-hormone therapy, which was the backbone of treating patients with endocrine or hormone-sensitive breast cancer, that using anti-hormone agents are very effective, but they don't cure patients. If you add what we call a targeted therapy, like a CDK4/6 inhibitor, to endocrine therapy, it makes it far more effective. Similarly, if we interrogate the tumor and find that there are other mutations present, that may allow us to use other targeted therapy with anti-hormone therapy. Again, enhancing the effect of the anti-hormone therapy and a better effect against the cancer. In triple-negative disease, as already mentioned, rather than simply chemotherapy, many of those patients get immunotherapy. Does it cure the disease? Not in most patients with advanced disease, it does not. However, we're learning how to optimize immune therapy and partner it with even antibody drug conjugates, that class of drugs that has a targeting antibody with chemotherapy drug attached to it. And there are other strategies to optimize the approach with immune therapy. And in HER2 positive disease, we've seen an evolution of treatment options for patients, not only with drugs like trastuzumab and pertuzumab, but also antibody drug conjugates like TDM1 or trastuzumab deruxtecan, and a variety of other drugs in development. So the net hope of all of these strategies is that we'll improve the outcome of patients with advanced disease, and at some point in the future we can say that we're curing some patients with advanced disease. We're not there yet. The other outcome of this is that these strategies have proven effective to a degree in patients with advanced disease, and they're all being evaluated in high-risk patients with early-stage disease to see if we can effectively cure more patients that have early-stage disease. So thank you so much for watching this session on the biology of cancer and the implications of that biology in terms of curing patients. I hope to see you again during another session from Yerbba.com. And if you have an opportunity, you can see other programs on topics related to breast cancer. We look forward to talking to you again in the future.